I'd like to welcome Dr. Stephen Black, who is a consultant vascular surgeon at Guy's and St. Thomas's Hospital and professor in venous surgery at King's College. He is known worldwide and is a pioneer in new cutting-edge technologies. Thank you for agreeing to do this podcast.
Pleasure, Neil. Pleasure to join you as always.
So I know you've been working a while on the Gore Fortegra stent. What exactly is this?
Yeah, so well, now newly named the Fortegra stent. When we started the study, it was called Viafort, but everything with Gore now will have a name that is linked to Viabahn as the basis for their system. So it's the Viabahn Fortegra stent is the official name. And what Gore have done is designed a stent that is specifically for use in the iliocaval segment, which we haven't had up until now. We've had stents that were designed for the iliac segments, and we've been using them off-label in the IVC. And I have one of the Gore stents here with me, which you can see. And the main features that you're going to get from the Gore stent, which is different to a nitinol stent, is the ability to axially load the stent. So you can see that you can kind of compress it in an AP diameter. And it's also got quite a lot of flexibility and a lot of ability to take twisting, which are those motions you can see there. And what is important from that, if you compare that to what we get out of a standard nitinol stent, which I can show you here, is a standard nitinol stent you can't squeeze from top to bottom. It doesn't take that axial loading. And so I think what that has done is give us something that is really designed more for that huge variation that you get in the IVC when you breathe. There's about 10 centimeters of compression of the IVC in the respiratory cycle. And we've got bigger sizes that are specifically designed for the IVC. So all of that is a real step forward for that cohort of patients that haven't had anything bespoke for them before this.
So this really helps meet a need that we haven't had in this space before
Yeah.
filled. So what's the data show? What was the study that was done? How was it constructed? And who were the patients? And what were some of the preliminary results?
Yeah, so the Gore study was a safety and effectiveness study for a device exemption, IDE study, as we're all familiar with. And it recruited patients in the United States and Europe. I was privileged to work with Kush Desai as a co-principal investigator on this study. And of course, there's a parallel study for the iliac segment that is being run by Kush and Kathleen Gibson in the US only. But the Viafort study was known then to bring this device to market. Recruited 89 patients in the United States and Europe, and the primary endpoint really was met with a very high patency rate of, I think there was 95% in the overall cohort at 12 months. And so this was really a lot higher than we'd seen in any of the other comparable studies at this stage. That was particularly for the IVC, the caval component of this device. Obviously, a slightly different patient cohort to what we saw in the IDE studies, because we recruited patients with filters and filter extraction that came out. So part of the study was you could stent after a filter extraction, which of course is a big component of what people treat in the US. Um, so really satisfactory patency. I think also it was important to note that in a lot of these patients with bilateral disease, there was quite extensive disease with almost 40% of this cohort needing stent extension below the inguinal ligament, which was really high. So a very complex group of patients with very satisfactory patencies at 12 months. Of course, we've got to wait now to see longer term data, but the short term was certainly good, and it met the primary endpoints.
So these were all patients with disease, either chronic disease or occlusions of the IVC. Is that correct?
Yeah, that is correct. So these patients had either occlusions of the IVC secondary to filter placement, or they had occlusions of the IVC secondary to atresia. So we saw a number of patients that we treated who had atresia as the primary um, uh, uh, reason the um, for their disease. And then we had a number of patients who had uh, um, post-thrombotic syndrome or PTS as the cause of their disease. So, of all the patients treated, the majority had IVC and bilateral iliofemoral stents, with 94% of the patient having lesions that spanned the IVC and bilateral iliofemoral veins, and involved the the whole of that iliocaval segment.
So some of these patients also have disease above the renal veins.
Yes,
How do
that's right.
you how do you manage that with this particular device?
So the way we used this device was because it comes in big sizes, and you've got a full range of device sizes up to 28 millimeters in diameter. Um, the way we configured this was to do a single large stent in the caval segment. So if it was suprarenal, we'd take a single large stent up to the hepatic vein, which is typically where the vein would come back to normal, and then you double barrel limbs in from below into that single large stent. So normally I would use a 28 millimeter proximal stent, and then double barrel 14 limbs into that stent.
What type of disease do they present with clinically? Were they all C5, C6? Did you have C4s in these patients? What exactly, how old on average? Because some of these patients can be quite young.
Yeah.
And how did, in the study, how did they present? And how are they, on the other flip side, how are they treated post-operatively? Because that's a key component for any of these reconstructions.
Yeah. So the median age of the patient group was 51, which speaks to the lower age group, as you say, with a range of 39 to 65. Um, Probably 60% of the population were male, and the majority were chronic disease with symptoms for more than 90 days. We did recruit some acute iliocaval DVT patients in the study, and overall, out of the total population, 80% of the patients had had a previous history of DVT. So there was a significant cohort of patients with effectively either acute DVT or post-thrombotic syndrome, but the majority of those were post-thrombotic. 20% of them were atresia, and as I said, 40% of patients had IVC filter placement with removal of the filter during the procedure. Uh, Very few patients were patients who were reported as having May-Thurner syndrome. There was only 10%. So this wasn't a cohort for nivel lesions per se. It was a cohort for um, more extensive disease in patients.
Study, how were the patients treated post-procedure? Because that, for us, with these particular set of patients, can be quite varied, and different practitioners do different things. What type of anticoagulants do you need after these types of procedures with this particular stent in this study?
Yeah, so our general practice was to leave this up to the individual clinicians and operators to make a decision as to what they wanted to do. I would say in my practice, what I typically do, and this was pretty consistent with a lot of the other operators, was we generally give patients 2 weeks of low molecular weight heparin as a split BD dose after stent implantation. And then we transition them to a DOAC, which in our practice we tend to favor a Pixaban or Eliquis, and we maintain that really probably in this patient cohort for life. I don't think anyone's brave enough at this stage to say with people with extensive iliocaval reconstruction, that they would be happy to stop anticoagulation. Although there probably are a few patients, particularly those who had an isolated IVC stenosis, where you could consider that.
I'm really also interested in those patients with atresia, although it's not a huge number. I'm wondering if those patients did any differently. They can be quite challenging sometimes. Sometimes I can't
Yeah.
see the vein on CAT scan, or I see looks like a small remnant. Uh, how were those patients treated, and was the sizing different for those patients, or did they do anything differently for those patients, or?
The Atresia patients made up a fifth of the overall cohort. So, that's going to be a smaller group of the patients, but they tended to be ones with more extensive disease where we had to bring stents down to the groin. And obviously, they are more challenging in terms of crossing the lesion and stenting them. What I ended up doing was using exactly the same size stents in the atresia patients as others. So we you typically open up the the iliac limbs from both sides, and then I'd use two 14 balloons in the IVC and then place a 28 millimeter stent. And I have to say, I saw some really encouraging results in this patient group because the uh, my experience with all stents has been encouraging, but the patency rates here seem to be a lot higher. And I think what we also noticed was less symptoms like back pain, which is anecdotal still because we haven't analyzed the full data set for that. But they did seem to cope better with the stent than perhaps we've seen in the past. So the treaters are a challenging group, but we had, as we say, really high overall patency rates in this group, and I think particularly in the IVC segment, which seems to stay open. Now, once you've got those big stents in it, even if you lose a limb, so the IVC patency was higher than the limb patency. So sometimes you might get partial occlusion in a limb, and then the rest stays open, and those patients still did a lot better. So it may be a component of the stent has got PTFE wrap on the nitinol, that's conferring some advantage.
So this looks like it's much more flexible than the prior stents, than the venous specific stents that we've seen in the last 5, 7 years. Uh, is it, does that help render some of not only its effectiveness long term? As you said, the IVC is constantly moving, and this seems to be a very different stent. I think the way it reacts to the movements of the IVC might play a role in this. Can you just explain a little bit more about the stent and how it not only implants, but also in terms of its results and its long-term patency?
Yeah, so I think that may be right because the construction of the stent does lend itself to a lot more flexibility. You can see it's more like a slinky that is connected by these PTFE bands, as you can see on the screen there. So you can really twist it, and it's pretty robust to that twisting. And then obviously the flexibility is very high because of that design. So I think that that ability, you would feel that that translates into longer term benefits. I mean, we're going to see that. We only have 1 year data at the moment, but the 1 year primary patency data here is really encouraging. If we look at each vessel region, the primary patency in the IVC region was 96, as I mentioned before, and 88 and 89 for the left and right iliofemoral segment, respectively, in this group. So, that's better than I've seen in some of the other ID studies, although these are not directly comparable groups. So that's it's hard to be firm on that. But I would think that something that has got much more natural flexibility has got to be an advantage, I would think, in the long run. And we do need these stents to last a long time, although we have seen data that supports the nitinol stents lasting out to 50 years. So we'll see.
And why do you think the PTFE coating helps? Do you think it's something that makes it less thrombogenic? What do you think is why these are doing so much better besides the flexibility and the changes in the construct.
Well, I think there's got to be some advantage to stopping that early stent wall adherence that we see, and I think as we've seen in the evolution of all other stents in other fields, is you start with bare metal and then you evolve to something else, and so this is a step in that direction, and whether we see other drug coatings come or other things that give an advantage, it'll be interesting. But obviously the PTFE is going to reduce to some extent thrombus adherence to the vessel wall, and that propagation into in-stent stenosis. I mean, obviously we're seeing some of that anyway, so it's not the whole story, but I think it's certainly part of it, and I think that's where we saw in one patient in particular that I had in my cohort blocked the common femoral vein components of the left iliac vein stent, but everything else above that stayed patent, and I certainly haven't seen that in other stents. So there may be something that allows even suboptimal inflow to maintain patency in a better way. Um, but we've got a bigger cohort of patients to analyze, and then of course we've got the iliofemoral study that Kathleen and Kush are recruiting to. So that will give us a more directly comparable set of patients to look at in comparison to the other ID studies that are completed.
I do want to highlight that point that you were bringing up, that this is really the next step in terms of the evolution of the venous stents. And we're seeing constant changes that are and advancements in this field. And I think this is actually a stepping stone to the next couple of steps. The allowing PTFE to be bound to the stents now allows other agents, as you said, to be bound to the PTFE. So I do think that this is an important advantage. I think this is an important advancement, and I really do look forward to more data being presented at future meetings from this data set as it continues to evolve. So congratulations, and thank you for sharing this data and some of your insights into how this stent works.
Thank you very much, Neil. My pleasure.